I'm Dr. Kalluri. I have been in the Tri-Cities area for about 15 years practicing orthopedics and spine surgery. Just this year, it's been about a year that we've been taken over by VCU, and it's been kind of a relief for me because I used to concentrate on the spine, and I've seen quite a lot of interesting surgical and non-surgical issues with the spine that I've taken care of over the last 15 years. It's a very complex situation whenever someone has issues with their spine and with their problems. I went to med school at Temple University and then trained at UMD Newark for my orthopedic training, and then went up to Chicago at Rush for spine training. Did one of the first minimally invasive spine surgery fellowships, and I've been doing minimally invasive spine surgery ever since, so I've got a lot of experience with that as well. I actually was an aerospace engineer, and I wanted something that was a three-dimensionally very challenging type of situation. One of the more interesting things about spine surgery is that people think, oh, it's about back pain, and it's really not. It's about what the nerves are doing, whether the nerves are working right, whether there's a problem with the spinal cord. Is it coming from the brain or the spinal cord? Sometimes that's hard to tell the difference between as well. So it's a diagnostic challenge many times. Sometimes it'll be pain from the neck, let's say, going down the arm, and it's shoulder problems. Sometimes it's a nerve pinch, and many times the two get confused. And even something crazy like ALS. They found years ago that ALS would be diagnosed many years after the patient went and had multiple spine surgeries to take care of a problem of nerves not working right, and turns out it was something different. So there's no easy answers with the spine, and we all know folks that have had spine surgery that don't do great, and we just don't understand why that is, and that's the kind of complexity that we deal with when it comes to spine surgery. So there are so many interesting patients. Sometimes it's an excess of interesting, but what I've seen, especially in the Hopewell area, I've found that there's a few folks that have a condition called ankylosing spondylitis. They'll come in, they'll have had a fall, and then they're like, oh, I'm better. In their minds, they're better because they're able to finally stand upright, and that's actually a bad thing because they have basically broken their back, which had already fused up with a condition called ankylosing spondylitis, which literally is what it is the entire spine kind of flexes forward and gets frozen in place. So you'll see the folks kind of not able to lift their head up when they're walking. And then they fall, and all of a sudden they're able to do it, and they think that's a good thing, but it ends up being a very unstable situation because the back is cracked in a way that makes it unstable. And so I've seen that a couple of times here. Sometimes we can do something about it. When we have to do something about it, it's a relatively quick thing that we have to do surgery relatively quickly. But for folks that we get to doing something like that with, it works very well. So one of the very interesting things that I've seen on several occasions over the years is that folks have come in with what looks like a stroke, and obviously it's a rush, right? Stroke is a problem, and people don't think about it from the perspective that if it's not a stroke, what is it? And maybe I've seen it frequently enough that I know that folks are seeing the concern for stroke and come into the hospital, do the CAT scan, it shows up nothing, and they still have weakness. So we have to break it down. If there's no facial weakness, but there's arm and leg weakness, don't hesitate to think about the cervical spine and stabilizing the folks with a potential stroke so that they don't cause further damage to the spinal cord. It's very common to have degenerative conditions in the upper portion of the spine where the wear and tear and bone spurs and disc bulges that form will squeeze on the spinal cord and cause damage to the spinal cord. That shows up as balance issues that may have been there for a long time. And then some folks, it shows up as one-sided weakness, arm and leg. And think about it like that. The spinal cord controls everything from the neck down. but it doesn't control anything above the neck. So if there's no facial droop, no slurred speech, but there's one-sided arm and leg weakness, then you really have to think, is there a spinal cord injury from degenerative conditions, not from a fracture or something like that. In that circumstance, it helps them to know, just stabilize the spine. Doesn't mean you have to put a collar on there. Be aware not to help to twist them. If there's a need to intubate or something like that, make sure not to kind of hyperextend too much to cause more damage, that sort of thing. Inline traction still applies for the neck, even with any kind of a potential injury. One of the biggest concerns had always been, is there a distracting injury that prevents them from recognizing a neck minor injury that could be potentially unstable, especially neck. I think in a circumstance where there's multiple injuries or the patient is unable to tell you, you still have to backboard them. In situations where the patient is alert and has no other distracting injuries, and you're stabilizing them and they're reasonably comfortable and are able to function, it's okay to just maintain inline traction and put them on a standard board and make sure that they're on a gurney and that they're not thrashing around or potentially aggravating an unstable situation. So you always have to think, is there an unstable situation? Even if you're not backboarding them necessarily every single person, is there an unstable situation? How do I tell if there's an unstable situation? And more importantly, is there anything that's happening that this patient cannot tell me what's going on? For example, they've taken drugs or alcohol. Quite frequently you'll see a high-speed motor vehicle crash, alcohol involved, and you say, well, this person can't tell me if they're feeling pain. And automatically that person needs to get backboarded. And I think you have to be abundantly cautious with that. So I think there's some clear-cut protocols for when like a level 1 trauma center needs to be the direction that you have to go, whether it's VCU or Chippenham. There's a level 1 type of injury that you cannot bring here. So that being said, there have been injuries like jump facets that I've seen here in the ER that I've taken care of. Relatively straightforward injuries where there's a little bit of neck pain, no neurologic issues, or the person's not complaining of, oh my God, my arm doesn't work or I can't walk. Those situations I can take care of them. But the reason for level 1 type of situation is more the ICU level care that they have to get, the multimodal care that they have to get from a trauma service and all of that stuff, all the associated injuries, which we cannot necessarily handle at a small hospital. But despite that, the number of things that I can take care of here are pretty dramatic. I mean, I've taken care of bad infections of the spine, fractures and dislocations of the spine, things that isolated injuries. If it's just a spine situation, I can take care of it here. I'm happy to do that, and I've done that over the years.